Good evening, everyone. Welcome to the live poster webinar. It's a great pleasure to welcome all of you today to this important academic session dedicated to one of the most clinically relevant topics in the mechanical ventilation, the patient ventilator asynchrony, physiological causes, and clinical aspects. On behalf of the BVI network, I would like to thank you all participants joining us from different countries and different time zones. Your presence reflects the growing interest of the patient ventilator interaction, respiratory physiology, and also bedside optimization of the mechanical ventilation. We are deeply honored today to welcome our distinguished moderator for today, Mauro Castro Sayed. Mauro will join me as a part of the moderation team.
Thank you all for joining us today from different parts of the world, I think. So we are delighted to have you with us for another PVI Network live author webinar. So it's a real pleasure to introduce Professor Evangelia Akoumianaki. Professor Akoumianaki is an intensivist and respiratory physiologist at the University of Crete. This is in Greece, and an international recognized expert in patient ventilation interaction and advanced respiratory monitoring. So today she will present her recent intensive care medicine paper entitled Patient Ventilator Asynchrony, Physiological Causes and Clinical Aspects. So Professor Akoumianaki, thank you very much for joining us today, and we are delighted to have you with us. So time is yours.
Thank you a lot for this invitation. It's my pleasure. Thanks a lot to everybody who is joining us today, Friday of July, and with the World Cup running. So it's a pleasure to see all of you. So I have to start saying that I was very happy to contribute to this article with Arnaud, Thille, and Gonzalo Hernández, because it addresses a problem we all face at the bedside. We often recognize patterns on the ventilator screen, but the difficult question is whether we truly understand the physiological mechanism behind them. So in the next 10 minutes, I will not try to review all patient ventilator asynchronies. I will focus on the central message of our article. Naming the asynchrony is only the first step. The clinical important step is to understand the mechanism, because the mechanism should guide treatment. So the reason we felt this article was needed is that patient ventilator asynchrony is often discussed as if it were simply a waveform abnormality. But in our view, it is better understood as a manifestation of neuromechanical mismatch. The ventilator waveform shows us the interaction between the patient and the machine, but it does not always show the patient's effort directly. So the same apparent event may arise from over-assistance, under-assistance, dynamic hyperinflation, or reverse triggering, auto-triggering, or, as we will see later, expiratory muscle relaxation.
Yeah.
Do you see them?
Yeah.
Okay. So as said, the reason we felt this article was needed is that patient ventilator asynchrony is often discussed as if it were simply a waveform abnormality, but in our view, it is better understood as a manifestation of neuromechanical mismatch. So the same apparent event can arise from different mechanisms: over-assistance, under-assistance, dynamic hyperinflation, reverse triggering, auto-triggering, or expiratory muscle relaxation. This is clinically important because the interventions may be completely different and opposite. So in one patient, reducing pressure support may improve the asynchrony, while the same asynchrony in terms of definition, not the mechanism, can be improved by increasing support in another patient. And this is very important because the waveform tells us that something is happening, but physiology will tell us what to do. So asynchrony is a sign of neuromechanical mismatch and not simply a ventilator waveform abnormality. And I included this slide not to argue against visual inspection of pressure time and flow time waveforms. Visual inspection is essential and remains the first bedside tool, but we need to be honest about its limitations. The available data show that conventional waveform inspection is often highly specific, 91 specificity in one study, but not sensitive. Sensitivity is limited. And you can see this study by Colombo. Among experts, the sensitivity was 28%, very low, meaning that many events are missed. High specificity means that if clinicians identify an event, they are probably correct, but many events are missed. Adding information about patient effort, such as in this study, when they included an estimated PMAS on the ventilator screen, increased sensitivity to 65%, but still 1/3 of patient ventilator asynchronies were missed, even with PMAS estimated recognition. So it was not real PMAS, it was an estimated PMAS. And this study showed that training also helps. This is shown by the Ramirez study. But even after structured training, recognition of the cause and management remains incomplete. So the issue is not simply whether clinicians can recognize asynchrony. The issue is whether they can identify the underlying mechanism. This is why in the article we moved from waveform recognition to physiological interpretation. And ineffective effort is probably the clearest example of why a waveform label is not enough. Here we have ineffective efforts, and you can see two different situations. In both situations, the patient generates an effort that is not detected by the ventilator. So this is ineffective effort, but the mechanisms are very, very different. On the left, the problem is over-assistance. So we have excessive ventilatory support. Large tidal volumes, prolonged inflation may promote alkalosis, reduce respiratory drive, and generate weak efforts. And these weak efforts are not able to trigger the ventilator. In this situation, reducing pressure support may actually improve patient-ventilator interaction. On the right, especially in obstructive patients, the problem is the opposite. The patient has high respiratory drive, high effort, so we don't have over-assistance, we have under-assistance. The patient must overcome high increasing PEEP before triggering the ventilator, but because increasing PEEP is high and dynamic hyperinflation is severe, despite high drive, despite high effort, the patient does not manage to trigger the ventilator. In this case, external PEEP and treatment of airway obstruction may reduce the threshold load. So the same diagnosis, ineffective effort, may require opposite ventilator adjustments. Double cycling is an asynchrony that is often easier to recognize visually and much easier to be recognized than ineffective efforts. And here we see in double cycling, we have two ventilator insufflations separated by absent or incomplete expiration. But again, the visible pattern is only the beginning. In fully assisted ventilation, such as in this case on the left, the classical mechanism is that patient's neural inspiratory time is longer, as you can see from esophageal pressure, than the ventilator inflation time. So neural inspiration lasts longer than mechanical inflation, and the ventilator cycles off too early while the patient is still inspiring, and the same effort triggers a second breath. However, this is not the only mechanism. On the right, we see a different mechanism. We have not a fully assisted mode, but assist-controlled mode, assist-controlled ventilation. So we have double cycling, but the first cycle is a time-triggered cycle, and the second cycle is triggered by the patient. This first cycling can be time-triggered, as in this case, but can also be auto-triggered, or can be also related to reverse triggering, or as we can see later, expiratory muscle relaxation. So the bottom line is that double cycling is easy to see, easy to understand, but not always easy to explain. So I will not read all this algorithm line by line. The important point is the logic of this slide. When we see double cycling, the first step is to ask, what is the ventilator mode? what is the respiratory drive of the patient, and what is the clinical context. In fully assisted ventilation, high drive and under assistance with early cycling off is usually the most likely mechanism. Then we may need to reduce cycling off threshold, so prolong the mechanical inflation, increase assistance because, as said, it is related to high drive, and treat the causes of high drive. Is it pain, fever, acidosis, sepsis, delirium, inadequate PEEP? In assist control ventilation, the question is totally different. Is the patient recovering and ready to move toward assisted ventilation, or is the patient still in an acute phase where lung protection and sedation remain priorities? So the right response depends on drive, mode, sedation, and risk of ventilator-induced lung injury, not just on the waveform. So to summarize, double cycling in fully assisted modes has as the commonest mechanism high drive, under assistance, and early cycling off. But when we have not fully assisted modes, we may have other mechanisms as well, like reverse triggering, auto-triggering followed by patient effort. So the first cycle can be a time-triggered cycle, and then we can have reverse triggering, can be an auto-triggered cycle, then can be time-triggered, and then the first breath on behalf of the patient, or can be triggering by expiratory muscle relaxation, and we will analyze this later. And why does this matter? This example is very useful because it shows why mechanism matters clinically. The waveform may look like double triggering or spontaneous effort, but in the cases reported by Thille and colleagues, the mechanism was reverse triggering in a patient who was brain dead. So passive ventilator inflation entrained respiratory muscle activity and caused reverse triggering, but the clinicians thought that these were patients' efforts. They were not patients' efforts, they were reverse triggered efforts. So efforts triggered by mechanical inflation. This was a reflex mechanism. So this didn't mean any activity on behalf of the brain stem. And when the patient was placed on CPAP, the abnormal pattern disappeared and apnea was observed. This distinction is not just academic. If this pattern is misinterpreted as spontaneous breathing, it may delay brain death diagnosis and interfere with organ donation. Up to this point, most of the discussion has focused on inspiratory effort, diaphragm activity, and ventilator timing, but patient-ventilator interaction also involves the expiratory muscles. This is something we often overlook because expiration is frequently assumed to be passive, but this is not the case in critical ill patients. More than 70% of patients under assisted ventilation may have active expiration, as we have recently showed in an article published in anesthesiology. In this tracing, you can see flow time and pressure time waveforms here. If we only looked at expiratory flow, time, waveform, and pressure, we might think that the patient is generating an ineffective inspiratory effort here. But when we look at esophageal and transdiaphragmatic pressure, there is no clear inspiratory effort. No effort here. So what is causing this deviation of the expiratory flow shape if it's not an effort on behalf of the patient? If we look at the PGAS, we can have the answer. So can inspiratory flow be generated without inspiratory muscle contraction? Look at this slide here. If we have active contraction of the expiratory muscles, we have expiratory flow. This is, I think this is something that everybody can understand. But if we have active expiration and increase in expiratory flow because of active contraction of the expiratory muscles, the lungs move to a lung volume below PEEP, below FRC, or below lung volume as determined by PEEP. So we move lower than FRC. So if we look at the pressure volume curve of the respiratory system, which is here, when we have active expiration, we have a decrease in end expiratory lung volume, and we move to a volume lower than FRC. At this volume, we have, at this point, we have a negative elastic recoil pressure of the respiratory systems. And when the expiratory muscles relax, so we don't have any active expiration, any contraction, then we have the negative elastic recoil pressure of the respiratory system that tends to insert flow into the lungs because the lungs want to go back to the FRC. So what do we have when we relax the expiratory muscles? We have inspiratory flow. And this is the mechanism how relaxation of expiratory muscles can generate inspiratory flow. And do we use it in do healthy subjects use these mechanisms? Of course, when we perform heavy exercise, we increase our minute ventilation by contracting our expiratory muscles. Then the relaxation of our expiratory muscles generates inspiratory flow and generates tidal volume. And this tidal volume is added to the inspiratory flow and the tidal volume generated by the diaphragm. So it helps the diaphragm and it helps us to generate very high tidal volumes and high minute ventilations. So gastric pressure helps us identify the expiratory muscle activity. When P gas increases during expiration, it suggests active contraction of abdominal expiratory muscles. And this matters because active expiration can change expiratory flow and airway pressure and may create waveform distortions that resemble ineffective efforts, auto-triggering, or even double cycling. This is the question that we posed in this article. So we aim to identify whether there are asynchronies related to active expiration, and these asynchronies are missed by pressure time, flow time waveforms, and are missed even if we use solely esophageal pressure. And the results were published in anesthesiology. So this example illustrates the point. The expiratory flow decreases in this pattern in a way that could be interpreted as an ineffective inspiratory effort. Here, here, and here. So look, this is CPAP and this is pressure support with pressure support, ventilation with pressure support on 5. And you can see in the expiratory flow these deviations that resemble ineffective efforts. But if we look at the esophageal pressure, we don't see any effort. We can see an effort here, 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 but no effort at this point, no inspiratory effort. What is happening? Look at the gastric pressure. We have active contraction of the expiratory muscles, huge contraction of the expiratory muscles, and this partial relaxation of the expiratory muscles because peak gas created by active contraction is not constant. It may fluctuate. This fluctuation causes these deviations in expiratory flow that resemble ineffective efforts, but they are not ineffective efforts because we don't have any inspiratory effort on behalf of the patient. This becomes even more important when expiratory muscle activity contributes to multiple triggering. If the patient actively contracts expiratory muscles, this changes like volume, pressure gradient across the respiratory system is changes, as we said, and when those muscles relax, as in this case, so you can see the contraction of the expiratory muscles and then relaxation. And the relaxation of the expiratory muscles triggers the ventilator, and then the expiratory muscles completely relax. We have contraction of the inspiratory muscles, and this is a patient inspiratory effort, but this first cycle is not an inspiratory effort on behalf of the patient. It's a cycle triggered by the partial relaxation of expiratory muscles. So the mechanism of this double cycling is related to partial relaxation of expiratory muscle. This slide is also a reminder that deep sedation does not necessarily mean passive respiratory muscles. Even when a patient appears deeply sedated, expiratory muscles may remain active, and sustained increases in gastric pressure can persist for several seconds. In this is the same patient, volume control, muscle relaxation, and then the muscle relaxation stopped, and we can see an assist pressure control mode by level, and we can see from time to time double cycling. And we thought that this is because patient started to breathe but the patient was still very sedated and had a low drive. That's why we saw esophageal pressure occurring at a rate of 5 to 6 breaths per minute. So we thought that we have to reduce sedation and the patient has very low drive, but the reality is not is that the patient had very high drive. If we look at the gastric pressure, we can see a huge contraction of the expiratory muscles that lasted for several seconds, in this patient for 15 seconds, and during this contraction, we had breaths triggered by the ventilator, so controlled breaths on top of active contraction of the expiratory muscles. So perhaps this is not, in this case, the reason was not low drive, and we should not further reduce sedation. So to conclude, the main message I would like to bring to the discussion is that patient ventilator asynchrony should not be reduced to waveform recognition. Waveforms are essential, they are available at the bedside, and they often provide the first clue. But the same waveform pattern may reflect different mechanisms: low drive, high drive, increasing PIP, reverse triggering, auto-triggering, or expiratory muscle activity. And because these mechanisms may require different and sometimes opposite interventions, the clinical relevant question is not only what asynchrony is this. The more important question is what physiological event produced it. So this is the practical message. Do not stop at naming the asynchrony. Ask what mechanism produced this asynchrony and what interventionally logically follows. And I think this is a good point to stop my presentation and open the discussion. Thank you.
Thank you, Professor Akoumianaki. Thank you for that excellent overview. And I want to ask you, just for open the discussion, you name these three asynchronies that represent very different physiological mechanisms and consequently different therapeutic approaches. So you also say that recognition is the first step, but why should we think beyond simply recognizing them on the ventilator screen? So if we send a message for the clinician, what makes these particular asynchronies so important for clinician to understand?
So why should we care, you would say? Why should we care about asynchronies?
Yeah.
Okay. I would say that we should care because patient ventilator asynchrony is not simply an abnormality on the ventilator screen. It is a marker of mismatch between patient demand, respiratory muscle activity, respiratory mechanics, and ventilator assist. So it's a signal. So it tells us something about the condition of the patient. So this, I would say, beyond proving that it affects outcomes, it affects winning, it affects mortality, I would say that it's a signal, and a signal cannot be ignored when we treat critically ill patients. For me, this is critical. So there are also studies showing that some asynchronies may be directly harmful. For example, we know that double cycling can produce and breath stacking and associated breath stacking if we have patients with recovering from ARDS, or if we have patients in the acute phase of ARDS, is harmful because we give 2 times the tidal volume that we prescribe, and this can cause excessive stress and strain. So this is obvious, something that we don't want. And there is also evidence that other asynchronies can cause eccentric contractions of the diaphragm, which could be injurious. Still not, we don't have a lot of solid evidence on this, but we have indirect evidence. For me, the most important thing is we have a lot of studies trying to prove whether asynchronies are harmful in terms of outcome, in terms of winning, etc., etc. And I think in the future we'll show that they are harmful. But even if we assume that they are not at all harmful in terms of long-term outcome, it's a signal. We should not ignore a signal in a critical ill patients. we never ignore a signal when we interpret arterial pressure waveform. Why should we do this when we interpret pressure time and flow time waveforms?
Do you think that the definitions matter? I mean that in the paper you mentioned that there is a double cycling, and in other literature they are mentioning double triggering, ineffective effort, missed effort. Do you think it is important to precisely define the various forms of the asynchronies?
So so definitions are important and they matter because we have to share a common language. If we don't speak the same language, we can't perform studies, we can't teach, we can't educate people. So we have to start with a definition, of course. Otherwise, we will test different things and we will talk about different things. So they are important. The problem is not to stick with a definition, not just define something, because many definitions, the definitions that we currently have, are umbrellas, and they include many different mechanisms. As I think we showed and we explained in this study with Arnaud, Thille, and Gonzalo Hernández. Ineffective efforts can be due to different mechanisms. So the next step, you identify the asynchrony, but what are you doing? Should you do something, and what is the action? So you have to understand what causes the asynchrony. The problem with the current definitions is that they don't tell us what to do. So we have definitions that incorporate many different mechanisms, and that creates confusion, especially when it comes to double triggering, double cycling, breath stacking, and reverse triggering. I think it's a chaos. It's a chaos, really.
Yeah, it's overlapping.
People are totally confused. And when I teach in seminars and webinars and in my ICU, people are struggling to understand what's the difference between double cycling, double triggering, and breath stacking and reverse triggering. And I tell them, if you understand the mechanism, then you will be okay. You don't need to agree with the definition given by Evangelia or Mauro or Ahmed. If you understand the mechanism, you know what to do. But of course, I said, I don't want to, it's not my intention to say that we don't need definitions. We need definitions to study, to educate, to share the same language. It's important. But we have to improve current definitions because they don't they don't imply the mechanism of the asynchronies.
So the next question, what should be the ideal classification for the asynchronies?
That's a very difficult question. If I knew the answer, I think I would I would write the best article in the
because some of the authors
years about asynchronies. But okay, so we need to give a general term and then specify. So ineffective efforts related to, I mean, maybe I can't find spontaneously the ideal term right now, but ineffective efforts related to intrinsic PEEP, ineffective efforts related to low, for example, effort. Low effort can be due to sedation, to muscular diaphragm weakness, etc. But this is very critical because it's totally different what you're doing. If it's intrinsic PEEP, you have to reduce support. For example, if it's due to weakness of the diaphragm, if it's due to sedation, you have to reduce sedation and to also take steps to wake the patient. So it's totally different. Sometimes you have to reduce support, other times you have to increase support. So it's the opposite direction. If it's double cycling related to active expiration, then the drive is high. It's not possible to have a low drive with active contraction of the expiratory muscles.
Yeah, because
so I would say that we
can see
a term that describes the waveform and additionally a term describing the pathophysiology, or at least giving some clues on the pathophysiology.
So what I understand from your proposal is that you prefer the mechanism, the classification based on the mechanism, rather than the classification based on the phases of the mechanical breath.
Exactly.
Because in the literature, there are different methods for classifications, the phase-based classification and also the mechanism-based classification. I think the most realistic one is to identify the mechanism, then based on that, you can go
because
for
people,
the
we have to tell people what to do. Don't not just name an asynchrony. They need to know what. Okay, they say, okay, you taught me what ineffective effort is. Okay, what to do? How do I understand whether it's low drive or high drive? So we have to give them a plan or some steps how to proceed, how to treat the asynchronies. This is for them, this is what it's critical, and this is for the patient also important. It's not just for us.
Definitions are not just semantics. So and we often spend considerable time and effort trying to classify them and name different types of patient ventilator asynchrony. However, as you said, a singular waveform pattern may arise from different pathological mechanisms. For example, double cycling may result from high respiratory drive and early cycling, but may also occur following reverse triggering on even after an auto-triggered breath. So comparatively, our understanding of reverse triggering itself has evolved considerably from 2013. So by the way. So it was originally described during mechanical ventilation, but more recently, Longini and colleagues demonstrate the presence of reverse triggering during pressure support ventilation has a auto-triggering as the main mechanism for this. And then more recently, Maria Vega Pitao and is part of the Stefano Nava team have now extended this observation to non-invasive ventilation. And this is from a patient that was sleeping, treated for treatation PEEP in obstructive apnea, and it's under mandatory breath, and then you have the reverse triggering. So does this evolution suggest that the understanding the underlying physiologically is ultimately more important than assigning a specific name to an asynchrony specific for reverse triggering?
So I would say that reverse triggering is a definition that implies the mechanism, because it implies that patient effort or diaphragm contraction, to be more precise, was triggered by the ventilator. So this is a definition that implies a mechanism. It's not so descriptive. Yeah. Of course, then it was used for, also outside this context. So if the mechanical inflection triggers the diaphragm and as a reflex mechanism, it can be caused by auto-triggering, because auto-triggering is a passive inflation. Okay, it can be also caused by non-invasive ventilation if we have, for example, controlled. So if we have a respiratory rate on non-invasive ventilation, for example, 10, 15 breaths per minute. So we have time-controlled breaths, time-controlled inflations. These inflations can also trigger the diaphragm. We are not aware of the exact mechanism of reverse triggering. It seems to be related to reflex mechanism. It seems to be related also to awareness. It's more uncommon in patients who have less sedation, who are arousable, who have a higher ARAS score. But so we don't know yet what to do. But again, we have to take steps according to the patient condition and the consequences of this asynchrony. So this is another aspect also. So it's the mechanism, but is it important, the causes or the injury imposed by this asynchrony, is it important for the patient? So if it's an early or a late cycling off without double triggering, for example, early cycling off without double triggering, you may have to accept it, because perfect synchrony in terms of cycling is impossible during pressure support. Totally impossible. You always have cycling of asynchrony. So, but if you have double cycling, this is important because it may cause injury.
Thank you.
Thank you, Professor
One more
Evangelia.
question, just a quick one. What have we learned along the way of reverse triggering knowledge? Do we have more questions than answers right now? What you saw on this?
So I love this type of asynchrony because we
Yeah.
first described it. What fascinates me is the entrainment process. Because if you look at the old studies in animals and in cats, it seems that our breathing and the way we breathe, it is influenced by external, let's say, oscillators. And mechanical ventilation is an external oscillator, but we may have also other external oscillators, like, for example, music or pacing or running. And there are studies showing that our breathing pattern is entrained to music, can be entrained to music, or can be trained to the way we walk or the way we run if we have a repetitive pattern, if we have a stable rhythm, let's say. So it's fascinating how one system is in synchrony or tries to be in synchrony with another system or with an external oscillator. So that's what fascinates me. So yeah, we have a lot of things that we haven't. It's an area that can be. I mean, we have a lot to learn on this. We haven't studied it a lot. Till now, we have focused on the consequences, and this is. I don't want to diminish this because this is what matters in critical ill patients. Is it dangerous? What are the steps that we have to take? But the mechanism behind, especially behind entrainment, is still largely underexplored. We know a lot about the consequences. When it causes breath stacking, it causes high tidal volume. It can cause Pendeluft, very nice studies by Yoshida group. But it also may be just a normal reflex mechanism, and you don't need to do anything about this. You don't need to try to eliminate this. So these are answers that we still don't have. But again, if we look at the patient and if we interpret the context, so is the patient in the acute phase? Is the patient now well? And waking the patient has good blood gases, adequate effort, adequate drive, is not struggling. So maybe just ignore it. Okay.
Yeah. Thank you, Professor.
My next question, it's about the recognition. Recognition is very important to recognize the asynchrony, but what are the limitations for the bedside recognition on daily practice?
So pressure and flow time waveforms give a lot of information. So if we are trained, it needs training. So this is a limitation, of course. But there is a lot of information that can be derived, especially from the flow time waveform, a lot of information. And I would say that the majority of asynchronies can be identified if you read well the flow time waveform. The problem is that the limitation is that it needs training. We don't have continuous monitoring. We cannot look at the flow time waveform of a specific patient 24 hours per day. And we know that asynchronies occur in clusters. So we can have periods without any asynchrony, and then we can have 1 hour with lots of asynchronies. In this hour, we weren't next to the patient because we took care of another patient, etc. So we may miss them because we don't have 24-hour monitoring. And especially they don't give us the mechanism. So they tell us that this looks like an effective effort. This is double cycling, okay, but It's double cycling, but what is the reason? It's double cycling because I have one inspiratory effort that cycles triggers the ventilator twice, or do I have a not a triggered breath and then this is difficult to recognize. Cycling off also is difficult. Cycling off asynchronies are also difficult to recognize. Auto triggering can be tricky. So we have easy asynchronies, and we have also difficult to recognize asynchronies, and they don't give the full the mechanism. But again, I would say that if we know our patient and examine the patient, for example, palpate the abdomen, see whether the patient has high or low drive. We can see it clinically by observing the patient. The patient uses accessory inspiratory muscle, is agitated, has tachycardia, high blood pressure. It's obvious. We don't need to measure any P.1, nothing. We see such a patient, we know this patient has high drive, even if P.1 is low. Or is the patient very calm, has alkalosis, respiratory alkalosis, no use of accessory muscle. So we can have a discrimination using the ventilator waveforms and patient clinical status. In difficult cases, we need signals. So we need esophageal and ideally gastric pressure monitoring. So in these cases, we need them. So we can't say that in 100% of the patients, even if you are a specialist, you will recognize the asynchronies. I can tell you that when we first examine expiratory muscle-related asynchronies, none of us could understand them without PGAS. And I'm talking about a group, for example, Professor Georgopoulos, my mentor, my ex-director, is, masters asynchronies and has passed years of his life analyzing waveforms. And we were not able to detect the mechanism without PGAS. So you definitely need signals in these complex situations. And I would like to add another thing. We discussed it earlier between us, that if you use these signals, you have a very rapid learning curve. So I can see it from my junior, I can notice it from my junior colleagues, because we use a lot of esophageal and gastric pressure, and in a very short time, they can recognize most of asynchronies without any education, because they have the real signal. So they are educated, they are trained to interpret the ventilator waveforms. So we can see it also as an educational tool, not only as a tool to detect and fully understand asynchronies. And then we can rely, to be honest, I rely on pressure and flow time waveforms in most of my patients, and plus the condition of the patient. Is the patient has an obstructive, a restrictive pattern, seems to have a high drive, a low drive? Is the patient in the acute phase, or is in difficult weaning? So altogether, in 80% of my patients, and I can understand the asynchrony and what to do, or maybe higher percentage. But still, there are some patients that we need signals like esophageal and gastric pressure or EDI.
Thank you so much.
Thank you, Professor. In practice, some colleagues ask me, does this patient need an esophageal balloon? So my answer is usually another question, and is related to how likely in this is that inspiratory effort is excessive. So that's information could be taken from the airway and flow, with occlusion maneuvers. And the other question is, how important would that information be for this particular patient? And then we have in this question include the context for this individual patient. And if the third question is good confirming it changed my management in this specific patient. So in that sense, I want to ask you if you feel like occlusion maneuvers can have a place in this interpreting when inspiratory effort is high and difficult to control And then in this specific patient, we need to use more specific or more another tools.
Okay, so we have tools, non-invasive tools, bedside available tools, to try to understand whether the effort is excessively high. These tools are, if I would classify them, I would start with with the clinical, with the clinical examination. So if my patient is using accessory inspiratory muscles and expiratory muscles, I never measure PIOC. For me, it's obvious that the patient has high drive and high effort. If you measure CVP and you see large negative swings in CVP, it's very obvious that you have high effort, okay? But of course, PIOC is a tool that is very, very easy to perform, very easy at the bedside. It takes 1 second, 2 seconds. But it's not an accurate measurement of patient effort. It is very reliable to exclude high effort or very low effort, but it will not tell you accurately the amount of effort that the patient is doing. First, because it's not esophageal pressure, it's airway pressure. And second, because it is an occluded maneuver. An occluded maneuver means that, I think maybe this is complicated, I will try to explain it simply. But during an occlusion, the pressure output of the muscle of the diaphragm is higher than during an unoccluded breath. Why is that? Because when we occlude the breath, we have the diaphragm is not we don't have any air into the lungs, any change in volume. So we have the curvature of the diaphragm that is kept constant. So the curvature remains. So the output for the same stimulation of the diaphragm is higher. When we breathe, we increase the volume. So for the same stimulation of the diaphragm, for the same phrenic nerve stimulation, we have less output because the diaphragm loses its curvature. So we always, during PIOC, overestimated the effort of unoccluded breaths. I don't know if it's clear. So I use it, but in most of the cases, it confirms what has been already suspected. For me, high effort is not the problem. Why is that? Because high effort is very obvious. The patient who has high drive and high effort is a patient, you can easily understand that this patient. The most dangerous patient is the patient with low effort, because this patient is the patient that does not trouble the clinician. It's very calm, has perfect arterial blood gases, no hypertension, no tachycardia, no agitation, no accessory muscles, nothing. But this patient may be over-assisted. This patient may develop weakness of the diaphragm, prolonged weaning, prolonged ICU stay, and maybe also death because of complications, infections, etc. For me, this is the most tricky, let's say, part of estimation of effort. Not high effort, but be sure that you don't have low effort or no effort at all. We may have pressure support and no effort on behalf of the patient, or just triggering of the diaphragm. This is the most, difficult to detect.
What's your input about the utilization of the diaphragmatic ultrasound to measure the patient effort?
So we started using it in our SAU, but to be honest, the intra-observer variability is very high. So for me, inserting a nasogastric catheter with a balloon is simpler, and measuring a pressure. If I measure the pressure, then you will measure the same pressure, and the next, even if you are not experienced. So for me, it's easier, and it has the ability to have continuous monitoring. So I use it on the screen, on the monitor of the patient. So I name it, for example, pulmonary artery or CVP, etc. And I can have this esophageal swing in every breath. And I find it simpler than ultrasound, but I have to be honest, I'm not an ultrasound expert. So maybe in the future it will evolve, and it will be also another tool to evaluate contraction of the diaphragm. So I don't want to underestimate the significance, or to say that it's not a viable tool, because it's bedside available, it's non-invasive, but it lacks this continuous monitoring, and it still has high variability.
There is a growing device in the market nowadays. It's like a continuous ultrasound for the diaphragm. Continuously, it measures the diaphragmatic excursion. Yeah, continuously measuring the diaphragmatic excursion, and also they are using it to predict the weaning failure from the mechanical ventilation in the pressure support ventilation. I think it's a promising device.
It will evolve. Yeah. It will be viable. Because now you put the probe, it depends on the side the probe is placed. It can be different, and a small difference can give very big deviations of the observed or the calculated parameters. So these are things that need to be solved, and then it will be a viable tool. I'm sure about this.
Thank you so much.
But again, it has to do with the diaphragm. So we have to keep in mind that critical ill patients, I think a significant portion of critical ill patients don't use the diaphragm as we use it. So the other muscles contribute to the effort. Yeah. And ultrasound cannot assess this. Esophageal pressure incorporates all expiratory muscle relaxation and accessory muscles and the diaphragm.
Thank you, Professor. So I think that probably another limitation of that diaphragmatic ultrasound could be in patients with expiratory muscle activity, and that's related related to the thing that you explained earlier in the mechanism that expiratory muscle activity can trigger the vent. The same mechanism can perform a diaphragmatic excursion, as overestimate the real diaphragmatic excursion. So
yeah, the excursion is a problem. Yeah, it depends also on the support. The higher the support you give, the higher the volume, the higher the exertion of the diaphragm. But this has nothing to do with the contraction of the diaphragm.
Yeah, sure. So we can say that probably occlusion maneuver have a place, has screening tools for the extremes, but if we need to quantify if this patient have a risk for high GEF or high lung stress, so we need reference tools, right?
Exactly.
And yeah, and regarding of these reference tools, you also said in your lecture that in some ways, in some aspect, esophageal pressure can be complemented by gastric pressure. So in patients that have a high expiratory muscle activity. So I think this topic is very interesting, because we often not use gastric pressure, and you show that we can be confused by micro expiratory activity and interpret that this patient have an ineffective effort and manage them like ineffective effort. So regarding for the additional physiological information that gastric pressure provide, not only in terms of recognition, but in terms of in understand the mechanism that produce them, you feel that this can change ultimately the guide of the treatment in this type of patients. So I mean, if you have a patient with expiratory effort and you use only esophageal pressure, maybe you can miss something. But if you add complementary gastric pressure monitoring, so you can have more information. The question is regarding to the impact of expiratory muscle activity in outcomes. I think this is a topic. Probably I don't have much information of that, But the only thing I know is expiratory muscle activity consumes energy. So that's important. But what do you think?
Yeah, so you're right. We don't have data on. So in this paper that we published in anesthesiology, we have only short-term recordings. So I don't know if we have recordings of longer duration, hours of duration, how often this asynchrony occurs, and in which patients. So we need prospective studies to answer to these questions. The management can be radically different, because if you have ineffective effort, because, for example, of dynamic hyperinflation, you think that you have expiratory flow and you have an ineffective effort like pattern in flow waveform. And you may think that this patient has dynamic hyperinflation, that's why expiratory flow is not returning to zero before the next breath. You have also a kind of ineffective effort like pattern. So the next step is to reduce pressure support. But if this is what the physiology says, what the guidelines say, what the review or the reviews suggest, that you have to reduce support to reduce dynamic hyperinflation and ineffective efforts. But if it's not ineffective effort, but it's expiratory muscle partial relaxation, this means high drive, and reducing support will cause, probably, I don't know, we have to examine this, but if you have active expiration, you have high drive. So the problem is not over assistance. And if you reduce support, you may exaggerate expiratory muscle contraction. So for sure, management is different because the mechanism is different. But again, to be sure in what to do, we need prospective studies. Expiratory muscle contraction we found that it's 70% in patients under assisted ventilation, and most studies that now are coming regarding active expiration report the same percentage. And this is not surprising, because expiratory muscles are recruited when we have an imbalance between the load imposed on inspiratory muscles on the diaphragm and the capacity of the diaphragm to respond to this load. And this is, universal in critical ill patients. We have patients with high load imposed on the muscles because of fever, of sepsis, of lung injury, of numerous factors, of acidosis, renal failure, etc., etc. And we have low capacity because in most of them we have diaphragm weakness because of ventilator-induced diaphragm dysfunction or because of critical illness-associated polyneuromyopathy. That's why expiratory muscles are recruited. In some patients, this recruitment of expiratory muscles is useful because it increases tidal volume, inspiratory flow, minute ventilation, and it assists the inspiratory muscles and assists weaning. But in other patients, when we have active continuous contraction of expiratory muscles, probably you have noticed it also in your patients, we may have reduced venous return, hemodynamic compromise, blood pressure decrease, and we have to sedate the patient because of this huge contraction of expiratory muscles. This may also impair other organs. We are studying this now, but we need time to have the first results. But I think it's a very interesting and until recently neglected component of patient-ventilator interaction.
Thank you, Professor. Very interesting.
Thank you so much. We have a question from the chat box. It's asking about the sources for the patient-ventilator interaction that explain the patient-ventilator asynchrony in a simple and practical way, like a book or literature. Do you have any suggestions?
Yeah, we have many reviews in the literature. And so we have many reviews written by our team, for example, from Professor Georgopoulos, old reviews, but with a lot of waveforms. We have we wrote recently a review also on this subject. I can send you, if you wish, some suggested articles, and you can disseminate them to the participants.
Yeah, as a complementary part for the
we have nice reviews on this. But also this review on anesthesiology has a lot of, it's not a review, this article on expiratory muscle has a lot of asynchronies and waveforms, and it's also informative.
There is a book, it was published recently, but it's not in English, it's Spanish. It was published by Gallard Adrian. I think he's one of the attendees. It's a promising book, but now I think he's in the phase of translation to the English, so probably it will be available soon in the market.
Spanish groups have also published numerous articles on this, on patient ventilator interaction. There are many reviews written by them as well.
So talking about Adrian Gallardo, we have a question from him. So he asked regarding expiratory relaxation in Dustrier. Adrian say it's very hard to see if you don't have exophageal and gastric pressure monitoring. So he asked, what do you recommend to diagnose it at bedside without these tools? So only...
EIT, you mean electrical impedance tomography?
Oh no, sorry. No. What do you recommend to diagnose the expiratory relaxation in Dustrier at the bedside without reference tool?
I would say again, clinical examination. In most of the cases, you can palpate the abdomen and notice that the patient is contracting the expiratory muscles. Sometimes you need to be, to leave the hand on the abdomen for several seconds to notice sometimes the contraction is not that, that obvious, but relaxation is very obvious. So start with this. And my fellows are starting with this. So they see an asynchrony and they examine the patient, they palpate the abdomen, and if they notice active contraction, they start thinking that this asynchrony may be related to expiratory muscle relaxation. But even if it's not, you have significant, information that the patient does not have low drive. No patient contracts the expiratory muscles with low drive. This suggests high drive.
So we can start with qualitative information, and then
you can start, and then you can also maybe check. Sometimes the expiratory flow waveform gives information. Unfortunately, we noticed that in 40% of patients, we had an expiratory flow that returned to zero despite active contraction of expiratory muscles. And this is related to airway closure. If active contraction causes airway closure, then we will not have an expiratory flow, no expiratory flow. In 60% of patients, we have this round shape in expiratory flow that indicates contraction of the expiratory muscles. Also, again, if you don't have any other tool, you can use also the CVP, because CVP increases when you have a significant amount of contraction of the expiratory muscle. So we have some things to, it's not that you, without Pegas, you have nothing. Of course, ideally, you have to use Pegas, but you have also, if you notice active contraction by palpation, then you don't need Pegas you need Pegas just to quantify it, but not to understand that you have contraction.
Sure.
Thank you so much. There is a technical question related to the esophageal pressure measurement. He's asking about the filling volume for the esophageal pressure. What's your recommendation regarding the filling volume?
A very good question, and a difficult one, because we don't have any standardized way to be sure that gastric pressure measurement is valid. So we use the volume recommended by the manufacturer. For example, for NutriVet, we use 4 milliliters, and then we check the signal, whether the signal looks like gastric pressure. So that's what we have right now. We don't have anything better right now. And of course, sometimes we use also chest X-ray to be sure that the balloon is inside the stomach. Because sometimes if you have, for example, diaphragmatic paralysis, bilateral diaphragmatic paralysis, gastric pressure is identical to esophageal pressure. And it's not because you don't measure correctly, it's because this is paradox breathing. In these cases, you need also to be sure that the gastric balloon is inside the stomach through chest X-ray.
Thank you so much. I think there is one question related to the auto-beep management by Mauro, I think.
Yeah. So thank you, Professor. We have discussed how to recognize the different mechanism underlying ineffective effort in your paper, right? So the next challenge, I think, is how to monitor our response once we intervene. So at the bedside, we often rely on the screen, and we can do expiratory occlusion maneuvers like POCC to estimate inspiratory effort. So one of the mechanisms of ineffective effort that you show us is related to intrinsic PEEP and dynamic hyperinflation. So in that sense, and recently, Gao and colleagues show that these measurements of POCC are influenced by intrinsic PEEP. So, and we can underestimate the true effort in patients with severe dynamic hyperinflation. So how should we safely monitor this patient during mechanical ventilation, particularly when ineffective effort occurred despite high respiratory drive and excessive inspiratory effort? When are bedside screening tools sufficient, and when should they be complemented by reference techniques in that sense?
So POC has problems when we have intrinsic PEEP. So it's not reliable and cannot tell us the amount of intrinsic PEEP. So one thing to do, the simplest, is just to try, fail, and try again until you don't fail. So try to reduce support, but not at a level that causes distress. And try to change PEEP at small steps, 1-2 centimeters of water, and see the response of the patient. So check the expiratory flow, see whether drive is reduced, because if dynamic hyperinflation is reduced, then also the drive of the patient and the effort of the patient will be reduced, because it will be easier. Check if you have ineffective efforts. If ineffective efforts are reduced, then you did well to decrease PEEP, to increase PEEP. But if you want to be 100% sure, then you need esophageal and gastric pressure, because only PDI will tell you the amount of intrinsic PEEP. Unfortunately, you need dedicated equipment to concurrently measure esophageal and gastric pressure and subtract PDI. So it's not possible. I think in most monitors, at least in the monitors that we use in our ICU, it's not possible to have esophageal, gastric, and a waveform that subtracts gastric pressure from esophageal pressure. I don't know if you have monitors that are able to do this. So you need either a laptop, dedicated software, or dedicated equipment to do this. But you can start with trying different levels of PEEP and support, and check the patient and check whether ineffective efforts are reduced.
Okay,
and of course, we don't forget bronchodilators, corticosteroids, etc., etc. So, of course, the medical intervention is valuable.
Yeah, I think that probably the device that we use to monitoring with esophageal pressure and gastric pressure are few of them, and we have some dedicated monitor. It's called FluxMed, and you can see gastric pressure, esophageal pressure, and the subtracted PDI.
I have a FluxMed also. Yeah, I use it also.
Okay.
Yeah,
so that's
but that's
nice,
what I'm saying, that clinicians need to have this. So you can have esophageal pressure on the monitor. You don't need any specific equipment. But if you want to measure PDI, transdiaphragmatic pressure, you need specific dedicated equipment.
Thank you, Professor.
Thank you so much. Maybe this will be the last questions. It's now we are in the era of the AI. And as you mentioned before, there is a limitation for the bedside recognition that we are not available all the time. Maybe you are working in a busy ICU. And as you said, that there are lots of clusters of the asynchrony might happen in your absence. So do you think that the AI and learning machines might help us to fill this gap?
I'm sure they will help us, but we still need training of these algorithms, because till now most of the algorithms were not trained with real signals, either with bench tools like estimated PMAS or simulated PMAS, etc., but not signals from the patients. So they were not trained with esophageal pressure or EDI, and none of them, as far as I know, was trained with esophageal and gastric pressure. We have to keep in mind that breathing has two phases, inspiration and expiration. It's not only inspiration that matters. So, but in the future, I'm confident that they will be, they will perform better, and they will be a viable friend. But they will, as said, they will not replace us, because we know the patient. They can't examine the patient. They are not aware of the condition of the patient, of the pre-existing lung disease, how the patient responds to our management. So we will use them as an aid, but we have to keep our expertise. We have to be very, very well educated on this. Otherwise, we will make mistakes, and this will be probably dangerous for a critically ill patient. So if we use them as a friend, as a tool that will enable us to detect something, to alarm us that something is happening, and give us some information about this, and then we interpret this information along with the clinical examination, our knowledge of physiology and of the patient's condition, they will help us a lot.
So now we reached to the end of our webinar today. It was our pleasure to have Professor Evangelia Akoumianaki from Greece, and also it was my pleasure to have our moderator for today, Mauro Castro Sayed. And we are honored today to have all the participants from different areas from the world with different time zones to attend our webinar. The record for the webinar will be available soon on the social media, and also for those who registered, they will receive email including the record as well. And we will try to get the references, as Professor Evangelia said. We will share with you the references for the study materials for the patient-ventilator interaction as well. Thank you so much. Thank you, Professor Evangelia.
It was my pleasure.
Thank you,
I really enjoyed our conversation, and thank you for the invitation. I really enjoyed it. It was my pleasure as well.
Thank you so much.
Thank you,
My
Professor.
pleasure.
Thank you.
Thank you so much. Bye-bye.
Bye-bye.
Bye-bye.